Hello, Nikita. Can you hear me?
Yeah, I can hear.
Yeah. Good evening, everyone. So, we welcome you to the first session of RadOcean 2B Viva session. So, in this session, we'll be taking two candidates. So, we'll do exactly like the present FRCR new reforms from the June session. So, we'll take 15 minutes for two candidates. So, 15 minutes followed by 10 minutes of feedback. So in this 15 minutes, we'll show you three cases and we expect you to cover those three cases with some small questionnaire followed by after each case. And so we'll do 15, 10, 15, 10, two candidates. If anything, you put in the chat box. And I also welcome my friend uh, Nikita. So she will be uh, co-hosting and she will help you also further. Nikita, you want to say anything?
No, I'm good. I think we can now begin if everybody is here.
Okay. We have candidate one.
Yeah, yes, good evening.
Yeah. Nikita, you can go start.
Yeah. Okay, great. 1 second. Let me just start my timer. I request all the other candidates to mute themselves.
Hmm.
Candidate one, you're ready?
Yes, I am. Good evening.
Yeah. Yeah.
Not me.
Yeah. Yeah. You're able to see the screen, right?
Yes, I am.
Yeah. You have the remote control access.
Okay. So I start?
Yeah.
Okay. So I've been provided with a CT scan of abdomen and pelvis in axial sections. History is not provided. I'll just scroll through the image before I start commenting. Okay, just figure out it's okay. Maybe I'll use the scroll bar then.
Yeah, that would be good.
These are plain sections, and I will just scroll once. Scrolling is slightly slow, please. So as I'm scrolling down, I've noticed that there are some dilated small bubble loops in the mid and the left aspect of the abdomen. I'm going down, trying to see for a transition point at this time. I'm suspecting a small bubble obstruction in this case. Okay, I haven't reached the pelvis yet. Okay, I'm reaching this pelvis. In the pelvis, I'm seeing dilated loops. So the iliac loops are also dilated. I'll go till the groin level to look for any hernia which could be causing the obstruction. So in the pelvis, yes. Yes, so I have noticed that there is a right-sided groin hernia, inguinal hernia, into which a bowel lobe has entered. And in this region, there is some fat stranding and some fluid surrounding this bowel lobe. So I believe that is a transition point for a small bowel obstruction. So this is a case of a obstructed or strangulated inguinal hernia, which is causing a small bubble obstruction. I will go back and check for any signs of pneumatosis or any signs of free air. I would usually in my regular practice, I would turn the lung window to check for any free air. Other than that, I'm not seeing any collections or any significant ascites. I would cross-check for the portal vein, any portal vein air or anything. Okay, this is moving quite slow, so I believe this is the only finding here. So this is a case of a small bowel obstruction caused by a obstructed or strangulated right-sided inguinal hernia. This is an emergency. I would inform the referring physician, and the patient needs urgent surgical consultation for surgical management of this hernia.
Great. Yeah, this is your next case. So this patient comes with lower back pain.
It's not on the screen.
Oh. Yeah.
Okay. So I've been presented with MRI images of a patient who's presented with back pain. These are the sagittal T2 weighted images. So I would just scroll the image and I would comment.
Just a second. I think we're not able to see. Just a second.
I don't have control, I believe.
Okay.
Should I request?
Yeah, I'll just give it. Yeah.
Okay. Yes. Okay, thank you. I will, I would just scroll the image and I would start commenting. So sagittal T2 weighted images, coming back to the central spine. In the, wait, it's moving all over the place. All right. So there is an abnormality, significant abnormality noted in the lower dorsal, mid to lower dorsal level, in which there is deformed or destructed dorsal vertebrae, and also there is also an abnormality along the posterior aspect. Oh, it's moving. It's moving on its own. 1 second. Let me just try to get it back. Okay, there. All right. So there is also an abnormality, and it's a kind of a anterior dislocation of the vertebral segment there, which is causing the posterior elements to move forward, and it is causing compression of the thecal sac posteriorly and of the cord too. So the vertebrae is quite distorted. However, if fracture or and a displacement, am I audible?
Yeah, no, your voice just broke up for a bit. Yeah, if you want, you can see the cervical spine now.
Yeah, I was saying. Okay, shall I load?
Yeah. Hello, candidate A?
I'm unable to load it actually.
Okay.
Yes. Yeah, it's come. All right. So this is a cervical spine sagittal T2 weighted image. Here I'm seeing so there are large bridging osteophytes anteriorly. So trying to scroll, it is not moving. Okay, so there is there are large anterior osteophytes there, which is seen. So it could be, so they're quite thick. So entity like a dish or hyperostosis, and I think that must have caused a fracture there, like a chalk-stick fracture at the thoracic level, which is causing displacement and compression of the thecal sac. Can I see a fluid sensitive image, a stir image?
Sure. Just a second, leave the mouse.
Yeah. It has not loaded for me.
Can you see it now?
Yes. Yes, I can. Okay, so I'm trying to scroll through the image. Again, we are back at the dorsal level. Yes, so the involved vertebrae appears quite hyperintense, so that could suggest there is edema, and this scrolling. Sorry, I'm stuck in one image for
Okay.
some time now.
Yeah. Do you want me to scroll for you? Are you able to see it now?
Yes, yes, slightly. I think there's a problem with the connection.
Yeah.
So I was saying, as I was saying, the first had any trauma, even a trivial trauma, because if it's this case of which looks like a dish, it could even a trivial trauma could mean that it can have a transverse fracture across both anterior and posterior elements and cause this abnormality. So check with the history of the patient, and this is urgent finding, and because there is a compression of the cord and the patient could have issues because of that, so the patient would need an urgent neurosurgical consultation and management for the management of this canal compression.
And how would you differentiate this from, say, an ankylosing spondylosis?
Yeah, ankylosing spondylosis, the anterior syndesmophytes would be slightly thinner, like they will be along the annulus fibrosis, and in dish they will be more confluent. They will be more thicker and flowing types, and it will be more concentrated in the cervical region. There will be more yeah, that is what I can think of. I know, and in ankylosing you would check the sacroiliac joints too, so it will be associated with sacroiliitis. You can check the interspinous ligament calcification too, which can come in ankylosing spondylitis.
I think I'll have to share my screen again for the next case. Give me a second. Yeah, you have the remote control. So this
Yeah.
patient comes with a headache.
Okay. So MRI brain of an adult patient, I believe, was presented with a headache. Shall I start with this image, or I can?
Yeah, you can start.
Okay. So that is a diffusion weighted image. I'll scroll through before I start commenting. So there. Okay, there is a large lobulated mass-like lesion, which is seen in the which is extending. Okay, let me just scroll once. Okay, it is epicentered in the left temporal region. It is also extending to the from the extending superiorly to the periventricular region, also involving the basal ganglia, and it is inferiorly involving extending down to cause mass effect on the brain stem. This lesion is hyperintense on diffusion, and it is causing mass effect and midline shift. I would like to further see this case on the ADC mapping to see if it is a true restricted diffusion. Can I open?
Yeah, you can have a look at the, it was showing diffusion restriction. I'll just, you can go to the T2 and other sequences, whichever you'd like to conclude.
Okay, I would go to a T2 sequence. So axial T2 sections show the lesion to be having an homogeneous iso to hyperintensity, and it also has an extra-axial component inferiorly. It is extending to the sulcal spaces and the basal cistern spaces, and that is where it is causing compression of the brainstem. So it is an either it is an intraaxial lesion with extraaxial extension, or it is an extraaxial lesion which is extending into the brain parenchyma.
Nikita, 2 minutes, last 2 minutes.
Okay. Can I see the flare, please? And the
Yeah,
contrast enhancer, I think I'll guess
I
directly
think you
go to the
can go with the coronal. Yeah, that would be good.
coronal contrast.
It was
Okay.
hyperintense on flare.
Yeah. So it's not loaded.
1 second. Leave the mouse. I have it.
Okay.
Yeah.
Okay, so it is not showing any significant contrast enhancement, and at this point, my differential diagnosis on the top would be that of an epidermoid with the restricted diffusion and a non-enhancement. And this also has an extraaxial component, so the epidermoid would be my first differential. In this case, and this is an emergency right now because it is causing so much of mass effect and midline shift. So I would immediately refer the case to the neurosurgery team and for immediate management.
Great. Yeah, I think we can stop here. So yeah, coming to your feedback, I think you did really well. You're very well prepared. Your pace is good. Radiology knowledge, picking up all the findings. I think in all the cases you got the diagnosis right. So this case, yeah, like you said, it was in epidermoid. I think if you had seen the T2 coronal, if you had time, we can see that it's an extraaxial lesion. And with so much of diffusion restriction and this lobulated T2 hyperintensity, epidermoid would be your only differential. So yeah, I think what you can add is you probably say like MDT referral, especially because it's a tumor.
Sure.
So that you can say, and for most of the patients, you can look for any prior images. So
Okay.
that also for comparison, those two things. But yeah, very small things only. Apart from that, I think I'll have to share my screen again to go to the other cases. So I'll just tell you. So in the dish case, that was the diffuse idiopathic skeletal hyperostosis, and you picked it up well after seeing the cervical this thing. But if you're in doubt, you can say like I would correlate with a radiograph or CT of this patient if it was there. And I think you mentioned the part about cord compression. I'm not sure because your
Yes.
voice kept getting cut in between.
Yes,
Okay,
there was
fine.
cord compression, so urgent.
Okay. Okay. Yeah. So urgent referral. And
Was there a history of trauma in that case?
trivial trauma. Yeah. I couldn't catch some of the things you were saying in between. It was getting cut. So yeah, I mean your approach was right. You did ask for whether if the patient had trivial trauma, then the examiner would ideally say, yeah, they had a trivial trauma. But either way, you were in the right direction. And the first
Nikita,
case also, yeah.
Nikita, just show the dish case once. People.
Yeah, no. Okay, fine, great. 1 second. I Yeah, so basically, this is the space between the two vertebral bodies. And as she said, this is all the ossification anteriorly, which we are seeing. And through, we have a carrot stick or a chalk stick fracture. I'll just show you the CT of this same patient as well. Yeah, so what we are seeing T2 hyperintensity is basically the space between the two vertebrae. It has got angulated and fractured through all the ossified ligamentous complex. Yeah,
Okay.
but it was good that you picked it up on the MRI itself. And
Asked for a comparison with CT, right? Yeah, I didn't
yeah,
ask.
you can say I will correlate with any
Mhm.
prior image or radiograph because that will solidify it more. Suppose you didn't have the cervical spine, then it was even confusing for a spondylodiscitis kind of picture if you hadn't looked at the cervical spine.
Yes.
But yeah, I think your pace and the way you speak, you are including all the negative points also. So that was good. And coming to the first case. Yeah, so this case, it's quite classical and commonly we get asked hernia causing intestinal obstruction. So it's better to aim for a full score on this. And I think you mentioned all the points basically for ischemia, you said pneumatosis and everything else. So if the patient is, you can also add if the patient is on table, I would immediately get a contrast study because we do need to rule out venous ischemia and other things. That's about it. Test everything you mentioned, pneumoperitoneum and everything that you have to look for. So overall, if we come to scoring, I think in most of the aspects you were 3 or 4. So yeah, keep doing what you're doing, and I think you did really well in all the cases. Yeah,
Thank
Suhas,
you.
you have anything to add?
Yeah. So candidate one. So I have noted few things. The pace and knowledge is good. So one thing is in, for example, in the hernia case, when you said
Mm.
you want to inform an emergency thing, so you have to use the word that you will pick up the phone and call. So
Okay.
it has to be done. They expect you to tell. And did you mention the type of hernia here?
Yes, I said inguinal.
Yeah, so when you say it, you can just say with one that is the differentiation with the pubic tubercle or the compression of the femoral veins. So you can give the substantiating points to say that you know what is the thing going on to differentiate both of those. And
Okay.
did you say that spinal cord compression? You said you have told, right? So,
Yes, in the other
so,
case,
so
yes.
in case you have a very complex case and you have something like a complication going on, if you think you may forget to mention it, you can immediately say that you'll park the case or you'll immediately pick up the phone and call the spinal surgeon of the to talk about the spinal cord compression, and
Okay.
later you can continue with the case. And other thing I noted is so when you're doing that MR brain case, so you were asking multiple sequence like flare, I want pre-contrast. So every time you say a sequence, you can just follow it up by saying that I want to see that if it is T1 hyperintense or hypointense, so that I want to rule out whether there's an intralesional fat or something. So you have to
Okay.
substantiate why are you asking. So
Why?
because if you ask and they in the new format they are not giving, they will not show what are the sequences which are on the list. So it is exactly like if you ask and if it is available they'll give. So most of the times they will give exactly what is needed. So they
Okay.
may just directly give you pre T1 and post T1 collab so that you come to conclusion faster and finish the case in 15 minutes. And other
Okay.
thing is in MRI brain case, you could also say that you were talking on midline shift. Also, you can say that even if you're not seen that finding, you can say I'm
Mhm.
also looking for uncle and tonsillar herniation, these kind of
Okay.
things. And there was a case of fracture, the banana stick fracture. So that time, anywhere if you have a doubt that you need a CT, and if you are not sure whether it is needed or you're concerned that radiation is a thing, so that time you can say that I will correlate it with the previous CT done instead of you advising, and you may be
Okay.
concerned that I'm putting extra radiation. So you can say that previous CT correlation. They wouldn't bother you by saying that it's not done. Do you want to do a new one? So you can say that. So I would score you knowledge 3, observations 3, reasoning 3, and safety also 3. I think you can just stress on the emergency part more. That's it.
Okay. Okay. Sure. Thank you. Thank you so much.
Yeah, welcome.
In candidate 2, are you ready?
Yeah, yes. Can you hear me?
Yeah, we can
Hello?
hear you. We can hear you. Can you?
Yeah, I can hear you.
Yeah, yeah. Suhas, I think you can start. I'll start your
Just
timer
give
when
me
you say.
time. I'm just opening cases. 1 second. Just give me a minute. Nikita, can you just mute if you are?
Yeah. I'm muted.
Nikita, if there is any queries, you can just answer those. By the time I open
Yeah,
I'll
sure.
just open this icon.
Yeah, so ankylosing spondylitis and dish, I think she covered the main points where dish it is more of flowing ossification, whereas ankylosing spondylitis it is thin calcification along the annulus. And sometimes in dish you see a thin lucency between the vertebral body and the ossification. And sacroiliac joints, basically dish can have ossification along the sacroiliac joints, but it does not have fusion. And ankylosing spondylitis will have bilateral sacroiliitis with erosions along with fusion in chronic cases. And also, dish is more common along the right anterolateral aspect of the thoracic spine because it is limited because of the pulsation of the aorta. We don't see it that much on the left side.
Uh, is the candidate 2 ready?
Yes, ready.
Can you be more? I can't hear you well.
Now can you hear me? Is it better?
It's very muffled.
Okay, 1 second. Okay.
Are you?
Is it better now?
Yeah, it's much better. Second. Yeah. Can you see the screen?
Yes, I can see the screen.
Yeah.
Yes.
Nikita, can you keep timer?
Yeah, you can start now.
Yeah. It's a newborn with respiratory distress.
I have been provided with the radiograph of the newborn who presented with respiratory distress. On the initial glance, I can make out there is lucent areas in the left lung occupying the left mid and lower zone. I am also able to appreciate that the rest of the remaining left lung is collapsed and it is compressed. I'm also able to appreciate the stomach or the fundic air bubble in the stomach, and the right lung appears relatively normal with no evidence of any similar lucencies. There is no evidence of any free air or pneumoperitoneum as evident in this radiograph. So in a child in a neonate who presented with respiratory distress with these findings, I would think in terms of a congenital diaphragmatic hernia. I would inform the findings urgently to the referring physician or the neonatologist as a child needs further evaluation and management in terms of surgery.
Okay. Do you want to comment anything on this radiograph? Anything else which you have not already commented?
So the lines and tubes.
Go on.
Yeah. There is a
Nikita, can you just mute somebody's sound?
the
Go on, go on.
Yes, the endotracheal tube. Actually, I'm not able to make out clearly. So the endotracheal tube is more into the right main bronchus. The tip is in the right main bronchus, I feel. Then there is a nasogastric tube with the tip in the stomach only. The nasogastric tube, the tip in the stomach, and there are the temperature monitoring probes which are placed on the right hypochondrium and right lumbar region. So other than that,
anything else you want to find out? Anything with the patient?
if the child had any antenatal scans, whether there was any abnormality detected on the antenatal scans,
Yeah,
or any prior radiograph.
yeah. What's the expected management here?
This needs urgent pediatric surgical referral, and the child needs to go for surgeries.
Is it elective surgery or emergency, you think?
It will be emergency surgery because the newborn is having respiratory distress at this point.
Okay. Any prognostic factors? What does it depend on?
Depends on the lung hypoplasia, the degree of lung hypoplasia, and the content or the duration of the. That's all. I think
Yeah.
lung hypoplasia mainly.
Okay, done. We'll go to the next case. So this is a 50-year-old who has come with pain in the knee.
Okay, I've been provided with the X-ray of the left knee joint, AP view. At the first instance, I can see there are some ill-defined lucencies or lytic areas in the proximal tibia with narrow zone of transition. There is multiple lucencies are noted in this region. There is also some irregularity of the medial proximal margin of the tibia. Similar small lucencies are also noted in the distal femur. I'm not able to appreciate any other obvious lytic lesions in the rest of the visualized skeleton. No, no obvious pathological fracture is noted. And I would like to see the findings on the orthogonal view if possible. So in the lateral radiograph of the knee, I can see that there is a large destructive lytic lesion in the anterior margin of the proximal tibia with a large soft tissue component. There is no obvious matrix, any significant matrix I can appreciate. And there is irregularity of the tibial margin. So in a 50-year-old patient who presents with a history of a large lytic lesion in the proximal tibia, I would like to think in terms of any metastasis, whether the patient has any previous history of any malignancy or any recent surgery. And I would like to compare the radiograph with the prior imaging if available. And I will inform the findings to the treating physician, and the patient needs further urgent referral for further workup.
Okay. So where would you refer this case?
I would refer the case to bone MDTs.
Bone MDT. Okay. So any other differentials?
Lymphoma of the bone also can present with similar appearance, but unlikely in the appendicular skeleton. Usually occurs in the pelvis. We can see a large lytic lesion in an elderly patient. Lymphoma can present like this.
So you're mentioning proximal tibia. Would you say any better characteristic location and thereby characterize?
GCT.
Okay. So you were saying in the AP image that it's narrow zone of transition. Now, what do you think?
No, sir. It is not a narrow zone, sir. Actually, it's a wide zone of transition.
Okay, done. We'll go to the last case. Sec. Just hold a minute. So this is a lady who has come with acute onset of pain abdomen. So whose age is 28. Okay, I'll just give you the abdomen. Just give me some time to load. Yes. Can you ask for control?
Sir, actually, I don't know how to ask for control. Can you please let?
Okay,
Sorry.
I'll give you control. 1 second. Nikita, where is it? Control thing.
On the top right corner,
Top right corner.
yeah, those three dots you can press and go to the last option in that
Okay.
remote control.
Okay, done. Candidate 2, you have the control.
Yes, I'm scrolling through the images. I have been provided with the axial CT section post-contrast images of a 28-year-old lady who presented with abdominal pain. First, I will scroll through the images before making my comment. See. This is IV and oral contrast has been given. At the initial instance, I can see that there is a heterogeneously enhancing area in the region of the right adnexa, abutting the right anterolateral border of the uterus, and also this lesion seems to be abutting the bowel loops on the right side, especially the colonic loops, the ascending colon. I'm not able to see any clear fat plane between the colonic loops and this heterogeneously enhancing mass in the right adnexa. The rest of there is also evidence of some pelvic free fluid, which seems to be hyper dense on this post contrast image. Left adnexa appears relatively free. However, there is no obvious bowel obstruction. There is no proximal dilatation of the bowel. So in a 28-year-old lady who presents with acute abdomen, first I would like to ask the patient whether there is any history of missed period, whether they have done any suspicion of ectopic pregnancy. So in that case, I would like to confirm my findings with an ultrasound to look for any obvious sac-like structure or any hematoma in the right adnexa, and I will confirm the finding to the treating physician. The rest of the abdomen appears relatively unremarkable. The kidneys, the pancreas, spleen, and the rest of the hepatic parenchyma, visualized hepatic parenchyma, appear unremarkable. If there is any other view that is available, I would like to go through the coronal images if possible.
Yeah, can you hear me?
Yes, sir, I can hear you.
So if in case, if I give a scenario where UPT is negative, so what would be your differentials for the same thing?
I would like to see the images. I would like to review my images again to look for the appendix. If I'm able to trace the appendix, whether this could be an appendicular abscess or appendicitis which has ruptured.
Okay. Anything else with adnexate, non
ovarian torsion, sir. Whether it could be which is an enlarged edematous right ovary. So, as I said before, I would like to confirm the findings on ultrasound if I can see the ovary and the vascularity.
Anything else? Because you can see the right adnexa is bulky or very, what do you say, the whole surrounding anatomy is lost. But if you're thinking of torsion, you'll have a midline, very asymmetrically bulky ovary. Anything else in adnexa which you can think of uh, ovarian lesion with such large collections?
Really?
Just the differentials.
There could be any malignancies, underlying ovarian malignancy with fluid.
Okay.
I'm not able to appreciate any calcification or anything within the lesion to say that it could be a dermoid cyst.
Yeah. Okay. Okay. We'll stop you here. Nikita, how long we took?
You have 1.5 more minutes left.
Okay. So, okay. Candy too. So you have good knowledge. Your pace is good. So I think you can just like build up more confidence, and you can be more expressive in the terms where you speak of regarding emergencies. So this was among three. This you did very well. So this one you picked all the findings. You started well. You said it's a contrast enhanced phase. You said you'll see the whole series before you comment. That's all a very good habit, so that you don't jump into a conclusion which is there in the upper abdomen which is out of interest. So the rest directly you went to the point that there is abnormality in the right adnexa, and you started describing the enhancement, the adnexa, the left adnexa is normal, and the relation surrounding to it. All that were fine, and later you also found lot of collection, and you said instead of whenever in CT or in ultrasound, unless you see a very clear fluid density or completely anechoic, better to not use a word free fluid. You can just say isodense collection, hypodense collection. That would be better. So you can see this is hyperdense collection. If you come back to the plane series, so this was plane, this was hyperdense. So you could also say a word. No need to come back and see, or no need. There's no need, particularly that the examiner will show you, that you will say that I will see in the non-enhanced phase the plane images that this is a hyperdense collection. So you can also, you came to the conclusion that you'll do a ultrasound, that was good. You'll check with the UPT missed periods, and later you'll look for a SAC, and you could have also used the word that it is a gross to moderate hemoperitoneum. So apart from this, in this case you did very well. The only thing you had to change is you said you'll inform the clinician. Here they expect you to say that you'll pick up the phone immediately, you'll call the gynec on call, and this is an emergency, that there is a concern for ectopic and rupture.
Okay, sir.
So that was the last case. You did well. So this was the second case. In the starting, you started lucent lesion in the proximal tibia, and you could have used the word I was waiting for you to use instead of proximal tibia, that it is epi and metaphyseal in location, and whether it is extending to the joint, matrix mineralization, and any pathological fracture. Then good that you immediately told that you want to see with orthogonal. So whenever you get extremity bone lesion, so make sure you put it together. They will wait for you to ask. The moment you ask, they'll put it. Then you started, and you could have used the extra words I'll just mention. You could have used the eccentric location, expansile 1 point, cortical destruction, and joint extension, and soft tissue component. So then you have to come to the conclusion, because they are not bothered with the diagnosis. They will expect you to brand this after your description that it is an aggressive lesion in the, you can say in conclusion, it's an aggressive lesion in the proximal meta epiphyseal region of tibia. And this is a 50-year-old. And you can also see very subtle lucences in the distal femur as well. So you can say that very rightly you mentioned the differentials of metastasis, very good. You want to check for previous imaging, previous history of any malignancies. Other differential you could have also considered is myeloma. This was in case myeloma case. And otherwise mylymphoma, every reasoning was good enough. So that was fine. So I'll just show you the last case. This one you got the findings and diagnosis. I'll just tell you because this is a basic starter image and basic starter case where they start with a chest radiograph. So I had given a history of newborn with the respiratory distress. The better way is you start with it's a immature image. It's a You don't see the epiphysis. No, you can say that it's a preterm neonate chest X-ray of radiograph of chest and abdomen, and afterwards always start with lines and tubes. So you don't go at the end and you don't want examiner to prompt and they will mark you unsafe if in case the tube is not in position. So because you know all the findings and diagnosis, but it is better you start with lines and tubes so that you don't forget at the end because of the all the findings in between. So after you mentioned all the lucencies, there is no diaphragmatic outline, and you can there is the left hemithorax is completely replaced. It's contralateral mediastinal shift, and that was all fine. So you could have told that you were dicey if you're what you are if you what the findings you were telling, you could just say firmly that endotracheal tube I can't see separately from the nasogastric tube with the oblique position of this radiograph, but wherever I'm seeing the end of the endotracheal tube, this appears to be lower for this kid, and we would do a repeat radiograph to just confirm the tip of the endotracheal tube. And nasogastrial tube, you told it is in situ and the stomach bubble. Then you could also add that it's a left-sided hernia, that this is a Bochdelic hernia. You could have used that word. And other things you rightly, very nicely mentioned that will correlate with the antenatal ultrasound. Other things to showcase your knowledge and to gain extra marks is you say the association, like I am also looking for vertebral bodies to look for any spina bifid or any vertebral anomalies or
Okay, sir.
anything, any association when you get a genetic or congenital defects. And other thing is when you get a radiograph and you know the diagnosis and findings, better to come in and out. What I mean is, for example, you are describing of the lucences, don't come out. You completely describe this. What is the lesion doing to the parenchyma? What is the surrounding doing to the lesion? Finish that and completely finish and see what is happening. Then you come out. Then you start seeing the right lung and all, because they are also bothered with approach. So I feel the scoring I would give you: knowledge, observations 3-3, reasoning 2, and safety 2. So I think you can just build confidence and stress on emergency, and you will be fine, I feel.
Okay, sir. Thank you.
Nikita, you want to say?
Yeah, nothing much to add. I think Suhas covered everything in detail. And going for the marking, I think I would give you a 3 in all of it, except probably communication, like how he said, the pick up the phone and inform, mainly for ruptured ectopic and things like that. And for the second case, since once you saw the lateral, you understood that, okay, there is more to this case, and I have said something that I should not have said. So in such cases, you can say that, okay, I retract my statement, what I made on AP. Now looking at the lateral, this is actually a much more aggressive lesion. Yeah. But apart from that, I think your approach pace, everything is good. You can just keep practicing every day, and yeah, then you'll get the hang of it.
Thank you.
Okay, then we'll wrap up this session. So next, before the Jan exams, we'll conduct 2 more sessions, and just unmute the group, and when we put the flyers out, you can just volunteer. So we'll follow it up with the people who are giving in January first. Then we'll come to the March session candidates. Okay, then bye.